Understanding joint pain in older adults, causes, care, and prevention. Joint pain is one of the most common complaints among older adults, significantly impacting mobility, independence, and overall quality of life. As the body ages, natural wear and tear, along with other age-related changes, can lead to discomfort, stiffness, and reduced flexibility in the joints. While occasional aches may be dismissed as a normal part of aging, persistent or severe joint pain should not be ignored, as it may signal underlying conditions that require attention. The causes of joint pain in older adults are varied, ranging from osteoarthritis, the most prevalent form of arthritis, to inflammatory conditions like rheumatoid arthritis, gout, or even injuries from past physical strain. Factors such as decreased cartilage, reduced synovial fluid, muscle weakness, and bone density loss all contribute to joint deterioration over time. Additionally, lifestyle choices, including sedentary habits, poor nutrition, and excess weight, can exacerbate joint problems. Understanding these causes is crucial for proper care and prevention. Early diagnosis and appropriate management can slow disease progression, relieve pain, and maintain joint function. Treatment options may include physical therapy, medication, lifestyle modifications, or, in some cases, surgical interventions. Equally important are preventive measures, such as regular low-impact exercise, a balanced diet rich in anti-inflammatory foods, and maintaining a healthy weight to reduce stress on the joints. By recognizing the factors that contribute to joint pain, older adults and their caregivers can take proactive steps to preserve mobility and enhance comfort. Education and awareness empower individuals to seek timely medical advice, adopt beneficial habits, and utilize available treatments to stay active and independent. Addressing joint pain holistically, through medical care, physical activity, and self-management, ensures that aging does not have to mean living with constant discomfort. Instead, with the right approach, older adults can continue to lead fulfilling, pain-managed lives. 1. Osteoarthritis. Osteoarthritis stands as the most prevalent cause of joint pain among older adults, a degenerative condition that develops gradually as the protective cartilage cushioning the ends of bones wears down over time. This cartilage breakdown occurs due to decades of repetitive joint use, causing bones to rub against each other with increasing friction. The resulting inflammation leads to hallmark symptoms including persistent joint stiffness, particularly after periods of inactivity, swelling around affected joints, and pain that typically worsens with movement but may persist even during rest in advanced cases. Commonly impacted areas include weight-bearing joints like knees and hips, along with frequently used joints in the hands and spine. Many patients describe a grating sensation or audible cracking, crepitus, during joint movement, while others experience reduced range of motion that compromises daily activities like climbing stairs or gripping objects. The progression of osteoarthritis often follows an unpredictable course, with some individuals developing only mild discomfort while others face significant joint deformity and functional limitations. Weather changes frequently exacerbate symptoms, with many patients reporting increased pain during cold or damp conditions. While aging remains the primary risk factor, secondary causes like previous joint injuries, genetic predisposition, obesity, and occupational stress on particular joints can accelerate cartilage deterioration. Unlike inflammatory arthritis conditions, osteoarthritis pain typically remains localized to the affected joint without systemic symptoms, though compensatory movement patterns may lead to secondary muscle pain in surrounding areas. The condition's chronic nature requires ongoing management strategies focused on pain control, joint preservation, and maintenance of mobility through a combination of medical interventions and lifestyle adaptations. 2. Rheumatoid arthritis. Rheumatoid arthritis represents a fundamentally different type of joint disorder compared to osteoarthritis, as it stems from an autoimmune malfunction rather than mechanical wear and tear. In this chronic inflammatory condition, the body's immune system mistakenly attacks the synovium, the protective membrane lining joints, triggering persistent inflammation that can eventually damage cartilage, bones, and surrounding tissues. Unlike osteoarthritis, which typically affects individual joints asymmetrically, rheumatoid arthritis usually presents with symmetrical symptoms, simultaneously impacting matching joints on both sides of the body, such as both wrists or both knees. The disease frequently begins in smaller joints like fingers and toes before progressing to larger joints, often accompanied by distinctive morning stiffness that may last several hours rather than the shorter duration typical of osteoarthritis. Patients commonly experience systemic symptoms including profound fatigue, low-grade fever, and general malaise, manifestations never seen in purely degenerative arthritis. The inflammation tends to follow a fluctuating pattern with periodic flares alternating with remission periods, though progressive joint deformity and erosion often occur over time without proper treatment. Characteristic visible changes may include rheumatoid nodules, firm lumps under the skin near affected joints, and distinctive finger deformities like swan neck or boutonniere abnormalities. Diagnostic blood tests often reveal elevated inflammatory markers and the presence of rheumatoid factor or anti-CCP antibodies, distinguishing it from osteoarthritis, which shows no such immunological markers. Left untreated, rheumatoid arthritis can lead to significant disability and may affect other organ systems including the heart, lungs, and eyes. Modern treatment approaches focus on early aggressive intervention with disease-modifying anti-rheumatic drugs, DMARDs, to slow disease progression, combined with biologics that target specific components of the immune response. Unlike osteoarthritis, where symptoms correlate directly with physical activity, rheumatoid arthritis pain and stiffness often improve with moderate movement rather than rest, presenting a different paradigm for management. The unpredictable nature of autoimmune flares requires patients to develop careful monitoring habits and maintain close communication with rheumatology specialists to optimize treatment regimens over time. 3. Gout. Gout is a distinctive form of inflammatory arthritis caused by the accumulation of urate crystals in joints, resulting from elevated levels of uric acid in the bloodstream. This metabolic disorder occurs when the body either produces too much uric acid or fails to excrete it properly through the kidneys. When uric acid concentrations become sufficiently high, needle-like monosodium urate crystals precipitate in joints and surrounding tissues, triggering sudden and excruciatingly painful attacks. The condition classically manifests in the metatarsophalangeal joint at the base of the big toe, a phenomenon called podagra, where about half of first gout attacks occur, though it can potentially affect any joint including ankles, knees, wrists, and fingers. These acute gout attacks often strike suddenly, frequently at night, with the affected joint becoming intensely painful, swollen, red, and exquisitely tender, sometimes to the point where even the weight of a bedsheet causes discomfort. The inflammation can be so severe that it mimics infection, with the overlying skin appearing shiny, warm, and stretched tight. Attacks typically reach peak intensity within 12 to 24 hours and may last 3 to 10 days if untreated, gradually resolving even without intervention, though subsequent attacks tend to last longer and affect more joints. Between flares, patients may remain entirely asymptomatic during intercritical periods, though persistent elevated uric acid levels continue promoting crystal deposition. Chronic untreated gout can progress to a debilitating stage called tophaceous gout, where large urate crystal deposits, tophi, form visible lumps under the skin around joints, in bursae, or even on the outer ear. These chalky nodules can erode bone and cartilage, leading to permanent joint damage and deformity. Gout shows a strong gender disparity, affecting men more frequently than premenopausal women, with risk factors including obesity, hypertension, diabetes, kidney impairment, certain medications, like diuretics, and dietary habits high in purine-rich foods such as red meat, organ meats, shellfish, and alcohol, particularly beer. Diagnosis typically involves joint fluid analysis showing needle-shaped, negatively birefringent urate crystals under polarized microscopy, though clinical presentation and blood uric acid levels often provide sufficient evidence. Treatment strategies address both acute attacks, using anti-inflammatories like colchicine or NSAIDs, and long-term management, with urate-lowering therapies such as allopurinol or febuxostat. Lifestyle modifications including weight management, dietary changes, reduced alcohol intake, and proper hydration form crucial components of comprehensive gout management to prevent recurrent attacks and long-term joint damage. Unlike other forms of arthritis, gout offers the unique advantage of being potentially curable through consistent uric acid control, making patient education and adherence to treatment particularly important for this painful but manageable condition. 4. Bursitis, inflammation of joint cushioning sacs. Bursitis is a painful condition characterized by inflammation of the bursae, small, fluid-filled sacs that act as cushions between bones, tendons, and muscles near joints. These sacs, numbering over 150 throughout the body, serve to reduce friction during movement. When irritated or damaged, they become inflamed, filling with excess fluid and causing localized pain, swelling, and restricted joint mobility. The condition most commonly affects joints that perform frequent repetitive motions, including shoulders, elbows, hips, and knees, though it can develop in any area where bursae exist. The primary cause of bursitis stems from repetitive stress or prolonged pressure on specific joints. Occupational activities like carpentry, gardening, or painting that require continual overhead arm movements often lead to shoulder bursitis, while prolonged kneeling on hard surfaces frequently results in housemaid's knee, prepatellar bursitis. Athletes, particularly those involved in sports requiring repetitive motions like tennis, elbow bursitis, or running, hip bursitis, face elevated risks. Acute trauma from falls or direct blows to joints can also trigger bursitis, as can underlying conditions such as rheumatoid arthritis, gout, or infections when bacteria invade the bursa, septic bursitis. Symptoms typically include a dull ache or stiffness around the affected joint that worsens with movement or pressure, often accompanied by visible swelling and warmth to the touch. Unlike arthritis pain which originates within the joint itself, bursitis pain localizes to specific points around the joint where bursae reside. Shoulder bursitis may cause difficulty raising the arm overhead, while hip bursitis often produces sharp pain when lying on the affected side or climbing stairs. Cases involving infection present additional symptoms like fever, marked redness, and intense tenderness. Diagnosis involves physical examination to identify tender buccal locations, sometimes supplemented by imaging tests like ultrasound or MRI to rule out other conditions. Treatment focuses on resting the affected joint, applying ice packs to reduce swelling, and taking anti-inflammatory medications. For persistent cases, doctors may recommend corticosteroid injections directly into the inflamed bursa for rapid relief. Physical therapy helps restore strength and flexibility while correcting movement patterns that contributed to the inflammation. Preventive measures include using protective knee pads for occupations requiring kneeling, taking frequent breaks during repetitive tasks, and performing stretching exercises to maintain joint flexibility. Most cases resolve within weeks with proper care, though chronic bursitis may require more intensive interventions like aspiration of excess fluid or, rarely, surgical removal of severely damaged bursae. By understanding and addressing the mechanical causes behind bursitis, individuals can effectively manage this painful but typically temporary joint condition. 5. Tendinitis, inflammation from overuse and injury. Tendinitis, also known as tendinitis, is a common condition characterized by inflammation or irritation of tendons, the thick, fibrous cords that attach muscles to bones. This painful disorder typically develops due to repetitive movements, sudden injuries, or prolonged overuse of specific joints. Unlike arthritis, which affects joints directly, tendinitis involves the structures surrounding joints, causing localized pain that worsens with activity. The condition frequently occurs in areas subject to repetitive stress, particularly the shoulders, rotator cuff tendinitis, elbows, tennis or golfer's elbow, wrists, de Quervain's tenosynovitis, and knees, patellar tendinitis or jumper's knee. The pathophysiology of tendinitis involves microscopic tears in tendon fibers that occur when muscles and tendons are pushed beyond their normal limits without adequate recovery time. Over weeks or months, this repetitive microtrauma triggers an inflammatory response, leading to swelling, stiffness, and tenderness in the affected area. Pain often develops gradually, starting as a mild ache after physical activity that progresses to persistent discomfort even during simple movements. In the shoulder, tendinitis may cause difficulty lifting objects or reaching overhead, while elbow tendinitis creates pain when gripping objects, and wrist tendinitis leads to thumb and wrist movement difficulties. Several risk factors contribute to tendinitis development, including sudden increases in physical activity intensity, improper technique during sports or work tasks, inadequate warm-up before exercise, and age-related tendon degeneration that begins after age 40. Certain systemic conditions like diabetes and rheumatoid arthritis may also predispose individuals to tendon problems. Diagnosis typically involves a physical examination to identify tender points and specific pain-provoking movements, sometimes supplemented by ultrasound or MRI to assess tendon damage severity and rule out complete tears. Treatment focuses on reducing inflammation and allowing tendon healing through the RICE protocol: rest, ice application, compression, and elevation. Non-steroidal anti-inflammatory drugs, NSAIDs, help manage pain and swelling, while physical therapy plays a crucial role in restoring flexibility and strength through targeted stretching and eccentric strengthening exercises. For persistent cases, corticosteroid injections may provide temporary relief, though repeated use can weaken tendons. Recent therapeutic advances include platelet-rich plasma, PRP, injections and shockwave therapy for chronic tendinitis. Prevention strategies emphasize proper warm-up routines, gradual activity progression, ergonomic workplace adjustments, and cross-training to avoid overloading specific tendons. Most cases resolve within weeks with conservative treatment, though chronic tendinitis may require several months for full recovery and carries risk of progression to tendon degeneration, tendinosis. By recognizing early symptoms and modifying contributing activities, individuals can effectively manage tendinitis and prevent recurrent episodes that could lead to more severe tendon damage. 6. Septic arthritis, joint infection requiring urgent care. Septic arthritis represents a medical emergency characterized by pathogenic microorganisms invading joint spaces, typically caused by bacterial infections, though occasionally viral or fungal in origin. Unlike mechanical joint disorders, this infectious arthritis develops rapidly, often within hours to days, with Staphylococcus aureus being the most common causative agent in adults. The infection usually reaches joints through hematogenous spread from distant sites like skin or urinary tract infections, though direct inoculation from trauma or surgery also occurs. Vulnerable populations include individuals with compromised immune systems, existing joint abnormalities, or those receiving immunosuppressive therapy, though healthy people can also develop this dangerous condition. The hallmark symptoms of septic arthritis include an intensely painful, swollen joint with markedly reduced mobility, accompanied by visible redness and warmth over the affected area. Systemic signs like high fever, often above 38.5 degrees Celsius per 101.3 degrees Fahrenheit, chills, and malaise typically distinguish it from non-infectious arthritis. The knee bears the brunt of about 50% of cases, followed by hips, shoulders, and ankles, with polyarticular involvement occurring more frequently in patients with rheumatoid arthritis or other systemic conditions. Patients frequently describe the pain as the worst joint pain ever experienced and maintain the joint in a flexed position to minimize discomfort from stretching the inflamed capsule. Diagnostic evaluation requires immediate joint aspiration for synovial fluid analysis, which typically reveals turbid fluid with markedly elevated white blood cell counts, often greater than 50,000 cells/μl, positive gram stain, and low glucose levels compared to blood serum. Blood tests show elevated inflammatory markers, CRP, ESR, leukocytosis, and frequently positive blood cultures. Imaging studies like X-rays initially appear normal but help exclude other conditions, while MRI demonstrates synovial enhancement and possible adjacent osteomyelitis in advanced cases. Treatment demands prompt intravenous antibiotics tailored to suspected pathogens after obtaining cultures, with initial empiric coverage for staphylococci and streptococci until sensitivity results return. Orthopedic consultation for therapeutic joint drainage, either via repeated aspirations or surgical irrigation, forms a critical component of management to remove purulent material and prevent cartilage destruction. The devastating consequences of untreated septic arthritis include permanent joint damage within days, osteomyelitis, and potentially fatal sepsis, emphasizing why delayed diagnosis remains the most significant prognostic factor. Recovery involves prolonged antibiotic therapy, typically 2 to 6 weeks, with transition from 4 to oral agents, alongside physical therapy to restore joint function after acute inflammation subsides. Preventive measures include proper wound care, prompt treatment of bacteremia sources, and antibiotic prophylaxis for high-risk patients undergoing invasive procedures. While mortality rates have decreased to less than 15% with modern care, approximately 30 to 50% of survivors experience long-term joint dysfunction, highlighting the critical importance of rapid recognition and aggressive treatment of this destructive joint infection. 7. Osteoporosis-related fractures, silent joint pain from bone fragility. Osteoporosis, a condition characterized by progressive bone density loss and microarchitectural deterioration, frequently leads to painful fractures around weight-bearing joints even without significant trauma. These fragility fractures occur when porous bones develop microscopic cracks that coalesce into complete fractures under normal mechanical stresses. The hip, spine, and wrist represent the most vulnerable areas, with vertebral compression fractures being particularly insidious, often developing gradually from routine activities like bending or lifting light objects. Unlike acute traumatic fractures, osteoporosis-related damage may initially cause only mild discomfort that progressively worsens as bone deformation continues, leading many patients to dismiss early symptoms as normal aging aches. In vertebral fractures, patients typically describe deep, localized back pain that intensifies with weight-bearing activities and diminishes when lying down. Multiple spinal fractures can cause visible height loss, kyphosis, dowager's hump, and chronic pain from altered biomechanics that strain surrounding muscles and ligaments. Hip fractures, while more immediately debilitating, often originate from accumulated microdamage in the femoral neck that suddenly gives way during minor falls. Wrist, culls, fractures frequently occur when osteoporotic bones snap during instinctive attempts to break falls with outstretched hands. The pain from these fractures often radiates toward nearby joints, complicating initial diagnosis as patients may mistakenly attribute their discomfort to arthritis or muscle strain. Diagnostic challenges arise because standard X-rays may not detect early microfractures, requiring advanced imaging like vertebral fracture assessment, VFA, by DXA scan or MRI to identify bone marrow edema patterns. Bone mineral density, BMD, testing confirms the underlying osteoporosis, with T-scores below -2.5 indicating established disease. Biochemical markers of bone turnover help assess fracture risk and monitor treatment response. Management requires a dual approach: acute fracture care through orthotic support, vertebroplasty for painful vertebral fractures, or surgical fixation for hip fractures, combined with long-term osteoporosis treatment using antiresorptive agents, bisphosphonates, denosumab, or anabolic drugs, teriparatide, romosozumab. Preventive strategies emphasize adequate calcium and vitamin D intake, weight-bearing exercises to stimulate bone remodeling, and fall prevention through balance training and home safety modifications. The profound consequences of untreated osteoporosis, including chronic pain, disability, and the cascade effect where one fracture dramatically increases risk for subsequent breaks, highlight why early detection and proactive management are essential. With approximately 50% of women and 20% of men experiencing osteoporosis-related fractures in their lifetime, this silent disease represents a major public health concern where joint pain may be the first and only warning sign of compromised skeletal integrity requiring immediate intervention. 8. Poor posture and body mechanics, the hidden cause of chronic joint pain. Chronic joint discomfort often stems from prolonged poor posture and improper body mechanics, creating cumulative stress on joints that manifests gradually over months or years. When the body consistently deviates from its natural alignment, whether from slouching at a desk, carrying heavy loads incorrectly, or maintaining imbalanced standing positions, it forces certain joints to bear disproportionate weight while others become underutilized. This mechanical imbalance particularly affects the spine's intervertebral joints, shoulders, hips, and knees, as they compensate for misaligned weight distribution. Office workers frequently develop forward head posture and rounded shoulders, increasing cervical spine compression by up to 20 pounds for every inch the head protrudes forward, while laborers who lift improperly transfer dangerous forces to their lumbar joints rather than utilizing leg muscles. The pathophysiology involves sustained abnormal loading that accelerates cartilage wear, strains joint capsules, and overworks stabilizing muscles until they fatigue. Initially presenting as intermittent stiffness or mild aching after prolonged positions, these biomechanical faults eventually progress to persistent joint pain as inflammatory cycles establish themselves. Kyphotic postures increase thoracic spine rigidity while forcing compensatory hyperextension at the neck and low back, creating painful joint overload at these transitional zones. Similarly, standing with locked knees or uneven weight distribution gradually damages patellofemoral and hip joints through abnormal tracking and uneven force distribution. Unlike acute injuries, posture-related joint pain typically develops insidiously, making sufferers unaware of their damaging movement patterns until discomfort becomes chronic. Diagnosis requires thorough postural assessment through static and dynamic evaluations, including gait analysis and occupational movement screens. Physical therapists often identify characteristic patterns like swayback posture, exaggerated lumbar curve with forward pelvis, military posture, overly rigid spinal extension, or scoliotic adaptations that create asymmetric joint loading. Treatment focuses on 3 pillars: postural retraining to restore neutral alignment, corrective exercises to strengthen underactive stabilizer muscles, like deep neck flexors or gluteus medius, and ergonomic modifications to workspaces and daily activities. Proprioceptive training helps patients develop body awareness to self-correct their positioning, while manual therapy releases myofascial restrictions that perpetuate poor mechanics. Preventive strategies emphasize micro breaks during sedentary work, proper workstation setup, monitor at eye level, supported lumbar curve, and conscious movement patterns during lifting, hip hinging rather than spinal flexion. Yoga and Pilates prove particularly effective for improving postural awareness and core stability. Left unaddressed, chronic postural stress can lead to premature osteoarthritis, disc degeneration, and irreversible joint changes, making early intervention crucial. By recognizing poor body mechanics as a modifiable risk factor rather than inevitable aging, individuals can proactively protect their joints through mindful movement and alignment awareness, preventing years of avoidable degenerative pain. The adage "your posture today determines your joint pain tomorrow" holds particular truth, as cumulative microtrauma from poor mechanics compounds silently until joints eventually protest with persistent discomfort. 9. Obesity and excess weight, the heavy burden on joints. The biomechanical impact of excess body weight places tremendous stress on weight-bearing joints, accelerating wear and tear in ways that often lead to chronic pain and mobility limitations. Every additional pound of body weight translates to nearly 4 pounds of increased force on the knees during walking, with stair climbing magnifying this pressure to 6 times one's body weight on each knee joint. This excessive loading particularly affects the cartilage in knee and hip joints, which normally serves as a smooth, shock-absorbing surface between bones. Over time, the persistent compression causes this protective cartilage to thin and deteriorate, leading to osteoarthritis years earlier than would typically occur. The lumbar spine also suffers under excess weight, as abdominal fat pulls the pelvis forward, creating unnatural curvature that strains facet joints and intervertebral discs. Beyond simple mechanical factors, obesity creates a perfect storm for joint deterioration through inflammatory pathways. Adipose fat tissue secretes cytokines and hormones that promote systemic inflammation, which not only sensitizes pain receptors but also chemically degrades cartilage. This explains why obese individuals frequently develop osteoarthritis in non-weight-bearing joints like hands, where mechanical stress alone cannot account for the damage. The metabolic changes associated with obesity, including insulin resistance and elevated blood sugar, further compromise joint health by promoting the formation of advanced glycation end products that stiffen connective tissues. These biochemical processes combine with mechanical overload to create a vicious cycle. Joint pain reduces physical activity, leading to further weight gain and subsequent increased joint damage. Clinical manifestations typically begin with morning stiffness and discomfort after prolonged standing or walking, progressing to constant aching that limits daily activities. Obese patients with knee osteoarthritis often develop a characteristic wide-based gait to reduce pain, which ironically places additional stress on hip joints. Diagnostic imaging reveals narrowed joint spaces, bone spurs, and subchondral bone changes more severe than would be expected for the patient's age. Treatment must address both symptoms and underlying causes, combining weight management strategies with joint preservation techniques. Even modest weight loss of 10 to 15% body weight demonstrates clinically significant improvements in pain and function for obese arthritis patients, with each pound lost reducing knee joint load by fourfold during daily movements. Comprehensive management includes low-impact exercises like swimming or cycling that maintain joint mobility without excessive loading, alongside dietary interventions targeting sustainable weight reduction. Orthopedic specialists may recommend unloader braces for knees or assistive devices to redistribute weight during walking. For advanced cases, bariatric surgery prior to joint replacement often improves surgical outcomes and prosthesis longevity. Prevention remains paramount. Maintaining a healthy weight throughout adulthood significantly reduces lifetime risk of debilitating joint degeneration. Recognizing obesity as a modifiable risk factor rather than an inevitable condition empowers individuals to take proactive steps in preserving joint health through weight management, ultimately maintaining mobility and quality of life well into later years. The relationship between excess weight and joint deterioration underscores the profound truth that when it comes to joint health, less weight literally means less wear. Conclusion: understanding and addressing joint pain. Joint pain in older adults arises from diverse causes, each requiring specific approaches to management and care. Osteoarthritis emerges as the most prevalent culprit, characterized by the gradual breakdown of cartilage and the resulting bone-on-bone friction. Inflammatory conditions like rheumatoid arthritis present a different challenge, where the immune system mistakenly attacks joint tissues, causing swelling and deformity. Metabolic disorders such as gout create sudden, intense pain due to uric acid crystal deposits, while infections like septic arthritis demand immediate medical intervention to prevent permanent joint damage. Mechanical stressors, including poor posture, repetitive motions leading to bursitis or tendinitis, and excess body weight, contribute to chronic joint deterioration through sustained abnormal forces. Even bone fragility from osteoporosis can manifest as joint pain when microfractures occur near articular surfaces. Persistent joint discomfort should never be dismissed as an inevitable consequence of aging. Seeking timely medical evaluation proves crucial for accurate diagnosis and appropriate treatment. Rheumatologists can distinguish between inflammatory and mechanical arthritis through blood tests and imaging, while orthopedic specialists assess structural damage and surgical options. Physical therapists provide tailored exercises to improve joint function, and pain management specialists offer strategies when conservative measures prove insufficient. Early intervention often prevents minor issues from progressing to debilitating conditions, particularly for autoimmune disorders or infections where delayed treatment risks irreversible harm. Diagnostic tools like X-rays, MRI scans, and joint fluid analysis allow precise identification of the underlying pathology, guiding targeted therapies from disease-modifying drugs to joint-preserving injections. Prevention remains the most powerful strategy for maintaining joint health throughout life. Regular low-impact exercise, such as swimming, tai chi, or cycling, strengthens supporting muscles without excessive joint stress. A balanced diet rich in anti-inflammatory foods, omega-3 fatty acids, colorful vegetables, and adequate hydration supports tissue health, while maintaining a healthy weight dramatically reduces load on weight-bearing joints. Proper ergonomics at workstations, correct lifting techniques, and posture awareness distribute mechanical forces evenly across joints. Protective gear during sports and comfortable, supportive footwear for daily wear help prevent traumatic injuries and malalignment. For those with existing joint concerns, assistive devices like braces or canes can redistribute pressure, while regular stretching maintains flexibility. Ultimately, joint health reflects lifelong habits and proactive care. While some degree of age-related change is normal, debilitating pain is not. By understanding the varied causes of joint discomfort, seeking professional guidance when needed, and adopting protective lifestyle practices, individuals can preserve mobility and quality of life well into their later years. The joints that carry us through life deserve thoughtful attention, not just when they protest with pain, but through consistent, preventive care that honors their remarkable durability and function. With knowledge and action, the golden years can truly remain mobile and vibrant.